Hello. Welcome, esteemed members of the practical and master class. I will continue to discuss the interventional pain procedure for glenohumeral joint osteoarthritis. Today, I will discuss the ultrasound procedure. You already understand the anatomy of the articular branch of the glenohumeral joint and the technique of the C-arm guided articular branch block of the glenohumeral joint. I explained my interventional treatment strategy for painful chronic osteoarthritis. It was designed to increase the range of motion by dissecting the fascia from the joint margin. Pain relief would be achieved by blocking the sensory nerve and increasing the free movable space to facilitate the joint's gliding mechanism. Once more, I will briefly describe the gliding mechanism of the glenohumeral joint. The convex humerus head glides and rolls on the concave articular surface of the scapular bone. The glenohumeral joint needs a relaxed, large inferior capsule to glide the humeral head inferiorly to achieve a gross axial abduction movement. What is the common feature of physical examination of advanced osteoarthritis and adhesive capsulitis? It is the capsular limitation of the glenohumeral joint movement. The abduction, external, and internal rotation show a proportionately limited range of motion. What kinds of pathology cause this kind of joint motion limitation? The main obstacle to smooth abduction is the failure of the inferior gliding mechanism. This challenge occurs in both glenohumeral joint osteoarthritis and adhesive capsulitis. Hence, if a patient cannot elevate their arm, we should consider a malfunction of the inferior gliding mechanism. The main limitation of inferior gliding is often due to the shortening of the inferior capsule or marginal spur of the humerus head or scapular glenoid. Similarly, limitations in external rotation are due to a too close approximation of the joint space, which can be caused by the shortening of the anterior capsule due to fibrosis. This pathologic biomechanics is typically seen in adhesive capsulitis and osteoarthritis conditions. Therefore, the treatment strategy of function and pain could be similar in both pathologies, relieving the limitation of gliding. In the chronic phase of osteoarthritis, adhesions and fibrosis of the joint capsule, narrowed joint space, and degenerative fibrotic myofascial structures block gliding movements. These factors significantly hinder gross rotational movements by limiting the gliding mechanism. The resultant deformities and chronic compensatory degenerative changes collectively contribute to the overall restriction of shoulder mobility in glenohumeral osteoarthritis. In this phase, intra-articular injection of steroids has little effect in relieving pain and increasing range of motion. So, we must adopt a more dramatic treatment concept for these restricted joints. You would guess the extended treatment mechanism of these injection techniques and how they work by observing the contrast spread pattern, understanding the advantage of the Botox mixture at the two injection points, and estimating the volume effect of the injectants. Botox paralyzes the stiff neighboring muscle, relaxing and allowing the glenohumeral joint to extend. The injectant volume separates the capsule and myofascial structure from the bone and joint margin, detaching these tissues from the labrum and the peripheral margin of the bony joint line. The increased gap between the joint margin and capsule allows the gliding mechanism during the abduction and external rotation. Why am I focusing on the target of suprascapular and subscapular nerve 1 cm distal to the joint margin? There are advantages to these injection targets. I have observed MRI findings of intractable glenohumeral osteoarthritis. Like knee osteoarthritis, bone marrow edema contributes to the intractability. The articular branch block and periosteal injection are the best options to relieve the humerus head's bone marrow lesion or the scapular bone's articular process. Now, I will discuss the ultrasound-guided procedure for osteoarthritis. As you suspected, the basic principle is the same. The ultrasound-guided protocol follows the same technique as an ultrasound-guided adhesive capsulitis injection procedure. In adhesive capsulitis, the first target is the coracohumeral ligament, and the second is the inferior capsular attachment site at the humeral neck region. But we need a modified technique. Here is how I modify the targets. The first modification target is the 12 o'clock position of the articular surface of the scapular bone. The second target is similar to adhesive capsulitis. But sometimes, the needle should be deviated to the more scapular attachment site instead of the humeral attachment side of the inferior capsule. Let me explain the model. To understand this better, I will remove the humeral head. It is an anterolateral view of the glenohumeral joint. This round area is the scapular glenoid joint surface. Here are the 12 o'clock and 3 o'clock positions of the articular surface. This area is for the supraspinatus tendon and the superior edge of the bony scapular glenoid. Here is the coracoid process. This area provides the attachment sites of the coracohumeral ligament, which are the first targets for adhesive capsulitis. My needle is directed to the posterior superior aspect of the coracoid process to approach the coracohumeral ligament. If I advance the first target upward, it will be in the superior aspect of the glenoid, underneath the supraspinatus, corresponding with the suprascapular nerve block of the C-arm guided technique. I inject the coracohumeral ligament. Then, retrieve and change the direction to the 12 o'clock position of the articular surface. I infiltrate the rest of the injectant into this target. The second target is the inferior capsule. I studied the contrast injection MRI study of this target, and it showed a wide range of extension of the contrast to the joint capsule, intra-articular, and periarticular space. So, while the humeral attachment site would be enough to relieve tension and pain, it would be more reasonable to extend the injection spread to the 3 o'clock position of the articular surface. I will remove the humeral head again to better understand. Here is the anterior edge of the bony scapular glenoid, which is the ideal of my second target. This area is the anatomical neck of the humerus head and the humeral attachment site of the inferior capsule. This approach is similar to the C-arm guided subscapular nerve technique, but the target is lower than in the C-arm guided procedure. This altered target is due to an inherent limitation of the ultrasound guided procedure. With these targets, I can relieve the tightness of the capsule in severe osteoarthritis, improve pain, and increase the range of motion. I will show several clinical cases. The quality of the movie image is bad. Please understand that these patients are elderly and unable to rotate their arms appropriately. However, the results have proven to be good for these patients. She is the last patient who previously showed MRI findings of severe recurrent subacromial bursitis and diffuse subchondral bone marrow edema of the scapular glenoid and humeral head. I aspirated the subacromial bursa and performed an injection procedure for these two targets. Thank you for watching. As esteemed premium members, your support greatly motivates my continued journey of practical pain management on YouTube. I look forward to seeing you in the upcoming videos.